Good morning, ladies and gentlemen. It is just gone 10 o'clock on a Monday morning. I don't know why I get the graveyard shift Monday morning, 10 o'clock, but welcome. Thank you for coming 2 weeks in a row. Apologies that I gave you the wrong information last week that we could potentially attend virtually. Maybe you'd like to take that up with your MP, because I would have seen nothing wrong with using people's time more wisely. And instead of asking them all to come into committee this morning. So apologies I gave you the wrong information, but thank you for making the effort to be with us this morning. First of all, I should welcome a couple of people. I welcome Bob Spencer and his Safeguarding Committee as observers. We will obviously throw open the floor to you to ask questions, but I'd ask that you don't vote on anything that we discuss this morning. Happy to have that informal view, though, and keen to make sure there is some alignment between the County Council's committees. I should just remind you for the record that today's meeting is being recorded, and because it is a public meeting and being recorded, that was why we couldn't have remote attendance this morning. But because it is being recorded, people are able to watch this live. You can also find the recording on the County Council's website, and I should say that the recording equipment will cut off 20 seconds after the equipment has stopped. And obviously, based on my earlier comments, all voting committee members are in person. I would ask our presenters to note that we have read the papers, I think this is a single item agenda really to focus in on adult social care. And the context to this, ladies and gentlemen, is principally that we are a health and care committee, and whilst County Councillor Anne Edgeler would tell us that we need to focus as much on mental health as physical health, I would also argue we also need to focus in on social care and make sure we have a good understanding of that. There is a new regime coming in within social care which will ensure that there is an inspection on a regular basis by the CQC going forwards from the end of the year, and we need to assure ourselves that we have done the appropriate and requisite job of scrutinising the work of and the direction of travel for adult social care. So, Zach, declarations of interest. Apologies, yes, that's always a good place to start.
Good morning, Chairman. I've received apologies from Councillor Charlotte Atkins, Councillor Perry, Councillor Bain, and Councillor Jones. I've also received apologies from Councillor Edgeler, with Councillor Peter Jones attending in her place as a substitute. And I've also received apologies from Paul Snape.
Thank you, and I know that the chairman will join us, County Council Chairman will join us very shortly, so he is not an apology, but he will be with us, and welcome Peter Jones to committee. So, item number 3, adult social care. Okay, declarations of interest. Now, well, I'm trying to get there faster, obviously, but I do accept that there is a laid-out format, so let's follow that this morning rather than being brave. Okay, so I think we're on item number 2. I'm just going to cross these off so I don't come back to it. We've done apologies. Item number 2, declarations of interest. Bernard, have you got a declaration for us?
Yes, thank you, Chair. I'm the Stafford County Council appointed governor at UHDB.
Thank you. Any other David? Welcome, David.
I'm an employee at UHDB, and I'm also a staff governor, a governor with Bernard at University Hospitals of Derby and Burton. So I'm a physiotherapist and a staff governor. Thank you.
Thank you. That's helpful. And nice to see those crossovers and experience in committee. Thank you. Any other declarations? No? Okay. Can I move on to item 3 now? You can. Okay, thank you. So item number 3. So we should welcome our guests. I think those who are new to committee may not be aware of the Cabinet member, Councillor Mrs. Julia Jessel. The 2 officers with us this morning are Dr. Richard Harling and Amanda Stringer, both welcome. We will throw the floor open to you. This is your agenda. This is your item. So, have as long as you want, maybe 10 minutes, 15 minutes maximum, but as as much as you want to cover, and I'll open it to the Cabinet member first.
Thank you very much, Chairman, and I can guarantee I certainly won't take 10-15 minutes. I will do just a very brief introduction because reports on our preparations for CQC Enhanced Assurance have been before this committee before, and this is really an update on our preparations for that inspection. We don't know exactly when we'll be inspected. It could be that we're in the next tranche, which will be between October and April next year, or it could be after that. It's a new system for adult social care. There are new staff being recruited, so there are a fair number of unknowns. We haven't got past practice to go by. But it is important that we can demonstrate that Scrutiny has an active role in our preparations and overview of those preparations for our CQC inspection. And that is why this report is coming to this committee. And certainly the proposal to establish a working group I totally support, because I think that will be a more meaningful way of Scrutiny playing a very active part in this process. The report, I'm sure Amanda will go through in more detail, and Richard, sets out our self-assessment of our strengths and our weaknesses. And I think the CQC recognise that no service is perfect, but you need to have a thorough assessment of your weaknesses and have a plan to address them. And I think that is very key to our success within this process. It is extremely important, not only in terms of reputation, but recruitment and retention of staff and the confidence that our users of services have, that we achieve as best an assessment as possible. Originally, CQC was saying that they weren't going to use the 4 categories that are currently used for clinical, for NHS services, but now they have resorted to confirming that they will be using the same terminology for their assessments. So I will leave my introduction there. As with Amanda and Richard, happy to answer any questions, but I'll hand over to Amanda. Thank you, Chairman.
As Councillor Jessel stated, I'm going to give a quick overview of how we believe local authority assurance is going to work, and then take you through the quality statements and our self-assessment.
Sorry, can I just interrupt, Amanda? I'm struggling to hear you slightly. I know the acoustics in here aren't very good, but if you could... Thank you.
Better? Can you hear me now? Thank you. So I'll give a quick update on what we know about local authority assurance, and then talk you through our quality statements and where we are in terms of our strengths and areas of improvement. So from 1st of April of this year, Health and Care Act 2022 gave the CQC Care Quality Commission regulatory powers to undertake independent assessments of local authorities. As Councillor Jessel pointed out, they are piloting this assessment at the moment, so a big caveat is that what I'm going to talk through is what we understand at the current point. So we believe that a local authority assessment will take about 20 weeks. We will be required to collate evidence and submit this, and that evidence will be primarily reviewed off-site. Our current understanding is that we will now take 2 days on-site with a team of assessors, and then a further 1-day virtual meetings followed by further meetings. So it's a slight update from what was included in the papers. As I say, it's changing all the time. We'll have the opportunity to review the report before it's published, and we will receive a rating as stated on the slides. In terms of the framework, included in the papers are the 9 quality statements that we will be reviewed on, and we're going to be scored on each of these quality statements. And then how we will be scored is by evidence. So we'll be scored, for example, for assessing needs on each of these types of evidence. So CQC will be very keen to speak to people and have evidence from complaints and compliments and the voice of the person, as well as doing 6 case tracking. So they want to see a case from start to end and understand that person's experience. They also want to speak to staff and leaders Included on the evidence framework is also overview and scrutiny, and also our own self-assessment. They will want to score the evidence provided by partners in terms of their views. That includes care providers, NHS partners, voluntary sector partners, etc. And there's then a category called process evidence, which is our documentation. So we're going to provide lots of evidence in terms of our practice guidance, our strategies, documented policies, etc., which CQC will use to assess us. And some of the quality statements also have outcomes, key performance indicators that they will measure. I'll just pause there for any questions before I go on to the quality statements. Is there any?
Thank you, Amanda. So, what questions have we got on process? I'll take Bob first and then we'll come to you, Bernard. So.
Thank you, Chair. When I look through the CQC evidence assessment, it seems to all but the last point is qualitative assessment. So it's experiences of people, feedback from staff, feedback from partners. That qualitative data is always very difficult to get, and also to sometimes wait and make sure that we do get the right answer. I suppose the question is, how satisfied are we that we've got the capability and ability to collect that quantitative data in all 13 themes within the time that we're given? Thank you.
We do it in a various number of ways. So they've stated in terms of compliments and complaints, and also local government ombudsman decisions that the CQC will take evidence that they have themselves as well. So they also have information from CQC providers and the feedback from people. We also do our own surveys. So when someone completes an assessment, we ask for feedback in terms of people's experience. We have a quality group that brings all that information.
I'm struggling. Could I ask you face the microphone?
Sorry.
And use the microphone, because I understand the sort of the desire to face Bob, but it's very difficult for the rest of us.
I'm really sorry. So we receive feedback from compliments and complaints. We also actively request feedback in terms of when people have received an assessment. We send out a little alert that says, how was your experience, to get that feedback. We also want to do more, so we're very aware that we want to do more individual qualitative assessments in terms of asking people for their feedback following that initial survey. So people can say they want to work with us to give more information.
Bob, do you have anything you want to come back on?
No, thank you. Thank you for that answer. It just strikes me as a huge, huge undertaking. I just want to make sure that we're in a position to deliver. Thank you.
Can I just ask a follow-up before I bring in Bernard? It strikes me that many people have been through, in various different guises, some of these inspection-type regimes. And I sit as a governor at a further education college, and they regularly have these sort of every 2 or 3 years inspections. Maybe not from the CQC, but the principle's still the same. And I wonder whether there is sort of a best practice approach by talking to some of the others who literally have 2 or 3 days to collate, a whole plethora of information. Because the last thing, it feels like a one-shot wonder, isn't it? And if we submit stuff that isn't full and complete because the timescales involved, is there a discussion that you could have with other providers? Because this is obviously new, so it's not within, other county councils, other social care providers, but is there other people within, inspection regimes that we might be able to learn something from? I think that touches on the point Bob was making.
I think we're taking advice where we can. So we're learning from our children's colleagues in terms of experience from Ofsted. Also, we're very linked into regional networks in terms of all learning together with other councils. And also our relationship with the NHS. Clearly, our NHS partners are very comfortable with CQC inspections. Although it will be a different assessment regime, we are taking learning in terms of their experience as well.
Thank you, that's very helpful. And obviously, Dr. Harling is part of ADAS as well, so I understand that. Okay, Bernard.
Thank you, Chair. There's clear mention in here that talks about, in the I statement there, about I feel safe and I'm supported and I understand and manage risks, any risks. How do you know that they're capable or competent to manage risks? And what about groups where English isn't their first language? How does your reach get out to them and make sure that the messages are embedded? Thank you.
In terms of the I feel safe statement, that's very much linked to our making safeguarding personal approach. So when we're taking people through that safeguarding journey with them, very much person-centred, we ensure that we understand what matters to the person. So do people understand the risk enlightened to them? We do quality audits on our safeguarding practice to provide us with that assurance. And then in terms of the English language, we do have access to alternatives in terms of language. So we have the language link tool where we can provide that translation service. And also we can provide documents in other languages as well.
This is so easy for me to say that people are listening and hearing what you say, but how do you know they understand it? I don't want to oversimplify that, because I know from having a portfolio at the district council integrating with mixed communities, talking's easy, but it's the follow-up and being able to put your arm around people and say, you do understand, don't you? Does that sort of practice exist?
I think my only answer to that is we were very strength-based approach for strength-based and practice. So we ensure that we consider people's personal goals and what's important to them. So when we're doing that practice, having that conversation and making sure we understand what that individual person's needs are to make that assessment. Yes, I'm sure we always want to improve on that.
Bernard, anything else on that? Can I just ask a follow-up, because we had a lot of conversation last week at committee regarding the role of Health Watch, and Baz isn't with us this morning, unfortunately. Is there a role for Health Watch in trying to just make sure that we've touched the voices which are seldom heard, maybe because of language barrier or because they're furthest from the market?
Yes, thank you very much. I mean, Health Watch, within their general remit, is to always be able to represent those difficult-to-reach groups. I think the thing is with this area of work, these are individuals who are in receipt of some social care services. So it is normal, good social care practice to ensure that there are those two-way communications. It isn't as though we're gathering the information from people who have not accessed the services. CQC is about how we run the adult social care. So those links, those communications, regardless of language, are there by virtue of the fact that we are assessing individuals where appropriate, providing them with services. I think it's fair to say that whilst we gathered feedback from the users of our services, some work has had to be done to ensure that that information gathered is actually gathered in such a way that it can be produced in a database. And I think that's the work, in all fairness, that has had to take place. You know, we've got that feedback, but it's making sure that it's in a format that you can produce as a database, because CQC, it's that documentary evidence that they need to see. So I think it just needs clarifying that we're not going out to the public in general for feedback. These are users of services and getting their feedback about how they believe that service has provided them with the support they need.
Yeah, I understand that entirely. Thank you. That's really helpful. If only because I recognise there's multiple touch points, huge numbers of touch points within what you do versus, many of the other people that we talk to. Can I bring in Janice, please?
Thank you very much, Chair. Good morning, everybody. When Bob asked his question, I'd just literally written down, how do you actually demonstrate the evidence here? And many of you will know that my background is in very much education and also have some affinity with this particular process. Some of the parts where you've mentioned about the surveys and the complaints, human nature by definition will tend to sway some of those more to those that have an issue and a problem, as opposed to those who have a compliment. So I'm a little bit thoughtful there as to, are we actually making sure that we are accessing all of the opinions? Those are good and not so good. And equally, the next part, and I only allow myself to use this word once a week because it still instills a sense of agitation, is called triangulation. So how do we know that these different sources, when they are compared against each other, are actually reflecting the issues and an accurate reflection of the situation? So how you intend to go through that process, I've already used it once. So as far as being able to make sure that we are reflecting an accurate impression of where we're at. Thank you.
Who wants to pick that up? Thanks, Amanda.
I think the point's very well made, particularly in terms of compliments. I guess previously we may have always focused on complaints because we want to do a better job, but actually there's a really strong focus through the assessment of actually focusing on our strengths as well. So compliments, for example, we would often allocate to the person, the practitioner, but also it's now thinking about who is the adult who's made that compliment. So what can we learn from that in the best practice? The self-assessments encouraged us to think about that triangulation in terms of actually where are their compliments coming to, centralising them as well and not just keeping them within teams so we can share that best practice, especially as Staffordshire is such a large county and we've got teams in different themes such as learning disabilities, older people, mental health, and ensuring that we're getting that triangulation of learning. We have practice forums, so we're taking the opportunity to take those learning, both from compliments, quality audits and positive compliments to ensure that we're sharing that message with our teams. But I guess that's one of the benefits of self-assessment has also focused us on the positive feedback that we get as well as perhaps also the improvements.
Janice, do you want to come back? Yeah, I've got a... Okay. Julie, do you want to?
Yes, as I say, I think the point was very well made, Janice, in terms of, ensuring you get that balance and not just the complaints, which we already have a comprehensive documentary system, as Bob Spencer will know from safeguarding. I think perhaps it might be a topic that, coming to one of your recommendations about a working group, that actually that is an area that could merit some deeper investigation to make sure that actually we give a fair and accurate assessment rather than we know when people feel something's gone wrong, they are very willing to complain. And people aren't quite so willing to compliment, but to make sure we get that balance and that we have that data, because it is a piece of work where Amanda and her team have had to do some more comprehensive approach to make sure that we can actually demonstrate that we have that. I think the other thing is as well is being able to demonstrate that we use what's called co-production now in terms of developing our strategies and policies. It's no longer good enough just to demonstrate you've gone out to consult, but that actually you use users, carers and their families to actually inform our strategic reviews so they have an input at the early stage rather than the traditional way, which is draft your strategy and then send it out to consultation. And I think that is something where we're a lot stronger on that now than we perhaps were in the past. Thank you.
Just in relation to that point, Janice, as well, There's 2 or 3 other feeds that I think we need to have on a more regular basis. I think corporate complaints gets looked at by overview and scrutiny at corporate review once a year. I think we need to be culling some of those, bringing some of those in relation to social care, providing we don't step on other committees' toes, so that we've got a early warning system potentially. I think the point about compliments is also a good one in terms of making sure there is a balanced approach in that. And obviously the other side and it may change, you know, a complaint may change over time as people's perception of the system changes. So we just need to make sure that's time bound as well. But equally I want to make sure there's a feed in terms of KPIs. I don't think we're there yet, but it's still an ambition of this committee, well certainly of the chair of this committee, to get there, so that we have a regular quarterly KPI pack, so that again we can start triangulating against information and then start raising information that raising questions where we are concerned by what it's telling us. It may be telling us the wrong thing, which is why we just need those. And obviously Health Watch is the other feed to that. So I think if we put those lots together, we probably will give ourselves greater assurance. Richard, you just wanted to come in.
Yes, so I think we will want to demonstrate to the CQC that we are competent, and we'll also want to demonstrate that we are self-aware, that we understand ourselves and that we continually learn. And I think what we'll want to do is we want to tell a story. We want to tell a story of here's some things that we are really good at, and here's some things where we need to learn and improve, and here's what we're going to do to address them. I think one of the roles that the working group could really help us with is, does our evidence fit that story? So if you were the CQC, would you believe our story based on the evidence available? A lot of the evidence that they will be looking at is within our control because it will be us giving it to them. One of the risks with this process is that they will also talk to people outside of that process. And whilst, of course, we can brief our staff and our partners, you're never quite sure what they will say. So we have to hope that the CQC handles outlier information sort of sensitively and puts things in balance and in context. But as I say, the bit we need to focus on is the evidence we give to them and that story, and to make sure they're consistent. And if I think we can do that, I think we're really well placed to get a good outcome from this.
Thank you, Richard. And obviously we can only focus in on the bits we can control in any case. So to that point. Philip, can I bring you in now, please?
Thanks, Chairman. Richard just answered some of my question. Some of it, I think the assessment is one thing, but it gives assurance to the public that we are in a good place and telling the story is the right thing. I noticed in paragraph 16 and 17 to me are the meat of the document, and whereas some people may think that throwing more money at something is a good thing, I often think, well, that can be 50-50 because it could just keep doing more of the same. I noticed in paragraph 17 quite a few of the acknowledged improvements. I'm going to be careful with my words for Richard's sake. I won't call them weaknesses, but they are things that we acknowledge we could do better at. And I've just flicked through all the appendices and I can't see sort of firm evidence of how that's going to improve. 17C in particular, about which answers Bernard's question to a degree, about the different sort of delivery. Representing a rural area, and I know Julia's got the same problem as Cabinet Member, don't rely on the internet. Not everybody can afford Starlink at £70 a month to get a decent IT connection. And we've got quite a few of our elderly are not very IT literate. So there's something about care and care in the community there, and the added cost and expense of delivering that to quite isolated properties and people. And so I think the document itself is good and it's in the right direction. I'm not going to do anything about that. I think Richard had pre-answered my question, but there is some work to do in paragraph 17 for us about just keeping an eye on the acknowledged areas of improvement and how those are going to be initiated. One of the problems about self-assessment, and I chuckled when I heard you on about colleges and SARS, it can be a lot of navel-gazing and paperwork for people involved, and I do wonder how much of this diverts attention away from the primary jobs of people of delivering a service to the public, and some of the collation of information that should be going on anyway within the organisation, that being digital, should be able to put us on the right way to deliver things and also highlight areas of concern and future improvement. So, I don't know whether that's a question or a statement.
Richard, did you want to pick up some of the strands from Philip's area? And I think the bit which Philip didn't touch on, but is sort of aligned to it, is obviously the use of innovation and technology. I think he inferred that, maybe said it as well. But are we going fast enough down that track? Because it's a mammoth job as the population ages.
Thanks, Chair. So we're getting a little bit into the self-assessment, but I absolutely agree that one of the challenges is where we say that we've got a plan to fix something, are you confident that that plan is robust? And that again, if you can play that role during our preparations, that would be a really helpful challenge for us. In terms of technology, I think the Council is very keen to pursue innovation, including the use of technology right across all services, including adult social services. We are implementing a whole range of different technologies and trying them out. In terms of access, the main route of access is still an analogue telephone, actually. That's how most people initially get in touch with us. They come through to Staffordshire Cares and they have a conversation initially and get routed after that. So it may be in the fullness of time that we look to do more of that with internet and possibly AI. But for right now, today, it is a reasonably traditional approach that I think does serve the majority of the population well. And I think as we develop that, we would of course want to be mindful to not excluding those groups who find engaging with technology more difficult.
Thank you, Richard. Philip, is there anything you want to just come back on that, or are you?
I'm content, Chairman.
Thank you. That's good news. Thank you. With you, Keith.
Thank you, Chair. You mentioned children's services a bit earlier on, taking some advice, looking at how they've done their quality assurance and all the rest of it. I'm just wondering, in terms of the structure of this committee and how we work with the districts as well, in terms of how elements of that might well come into it, because obviously children's services are delivered through districts as well. Is anything like that going to be getting involved, or is it more going to be we set our own ways of going forward? Is there some flexibility in the assessments and the KPIs that we set ourselves to be able to then report that back to the CQC and that process? Because obviously I do think that there will be difference. We've already mentioned it between rural and urban areas, and I just think that sometimes there may be a different picture in different parts of the county, and it's whether or not we can pick up on those differences during the assurance process and being able to pick that up in terms of how it's structured, so that we understand where improvements might need to be made as time goes by and all the rest of it. So I think mine's just really about how are we going to get into that nitty-gritty? What's the role of the working group in terms of developing those more flexible approaches, if that's indeed what's needed in your own mind, or whether we are just going to be dictated to by the CQC more than giving our own flexibility a chance to be able to improve, particularly the areas that are mentioned previously. I think it was 17, is it? Yes, 17, and the actual document itself, because there's quite a lot of things there that need, as you've identified, for improvement as well. And I do like the idea of always bringing in the idea of positive feedback as well, you know, so we can concentrate our services where they need to be concentrated, I suppose, is what I'm trying to do.
Before I bring in the Cabinet Member, I don't particularly want you to reference comments on the terms of reference of the working group, because I think that would be inappropriate, because it's for this committee to set the terms of reference for the working group, I think, or at least to agree the terms of reference with committee, rather than otherwise you'd be at risk of marking your own homework. Julia.
You're absolutely right there, Chairman. I wouldn't deem to do that. All I would suggest is that in view of the timescales, October is not that far away. We do need to make sure we're as well prepared as we can be. I would respectfully suggest that actually looking at our preparedness for CQC inspection is perhaps a priority. I think if you're not careful, your attentions and your time could be absorbed by a wider agenda, which you may wish to do at a later date. But I'm very conscious of the fact that October is not that far away. It could be our inspection is April next year or later, but we do need to make sure that we are as well prepared as we can be. And I think the working group could maximise the benefit to the whole process by concentrating on the CQC elements in the first instance. Thank you, Chairman.
I think Keith also was talking about the differences between rural and urban areas, and I think the point there I'm assuming there is a standard journey for anyone requiring social care, whether regardless of where you live, but based on that. Is that the case? Who's picking that up?
So in terms of the social care journey, yes, it is pretty standardised. So typically it will involve a first contact with the council through a telephone or the internet. It may then involve an assessment by a social worker, which could be virtual or it could be in person at your house, depending on what's most appropriate. And then for those who need services and are eligible for county council funding, it might involve home care or a PA or a care home placement. So that process is pretty standardised across the county, and we can measure it in different districts and boroughs and different teams. So we understand whether there is variation, and we can address that where necessary. That said, we do try and make sure that the experience is tailored to the individual. So it's an experience that works for them within the resources we've got available. So that the social worker is going to be having a conversation in a place that's relevant to them, about a topic that's relevant to them, which I hope takes into account any rural issues as well as other demographic issues and protected characteristics and all of those sorts of things.
Thanks, Richard. Keith?
Well, it was really just to say, as I say, that as long as it's being picked up already, it sounds like it is, you know, that you are doing it through different areas within the county, and then you're reacting to it already, so that's already a big tick in the box, isn't it? You know, so thanks very much. Much appreciated. Thank you.
Was there anything further within what you were raising that you wanted to pick up on specifically? Okay. I think the suggestion of prioritising the strands of activity for the working group is a sensible one, so that we don't try and do everything on day one when actually it probably should be an ongoing strand of activity. Okay. Useful. Thank you. And Jill Hood.
Thank you, Chairman. Good morning. I see in your 13 quality statements and themes that you seek experience from people who receive care, unpaid carers and their reps. Some of the care that's performed on people who require the care, I don't know, 1 visit, 2 visits, 3, 4 visits, is of the most intimate experience. And people are reluctant to raise anything that is not hurting them, but that's really frustrating them or making them unhappy. Reluctant because, believe me, in my experience through Age Concern, they believe that there will be recriminations. So how are the CQC going to make sure that people are not afraid to raise an issue? In my experience, there are lots of issues. Once a care package has been arranged by the county council, social workers, they go into people's homes, and then it's almost as if there's no assessment after that. It's almost as if, you know, they open the front door, they go in, they do the work, and they're not held to account. That concerns me. And because people are so reliant on carers, as I say, they're not going to complain, and they will put up with some things that I personally wouldn't be happy about. I witness this time after time, and I just wonder how we're going to guarantee that these people are included in assessments and that their voice is heard, because many of those people have no voice. Thank you, Chairman.
Thank you. Richard, you seem to be grabbing for a microphone first, so...
Yes, so all of those people will have been involved in an assessment initially to determine what their needs are and how those can be most appropriately met, and indeed whether or not they're eligible for funding from the county council. Where we have providers contracted to provide that care, we do hold them to account through the contract. So the contract does specify a series of quality standards. It specifies a price, it specifies a range of other requirements from that service. We do manage those contracts actively. We do have a quality improvement team who will go around and at a provider level just keep an eye on those services and what they're doing. And there is always the opportunity for people to raise concerns either with the provider or with us directly. We do a 6-week review typically, so that we just keep an eye on someone to make sure they're settling with new care. That doesn't mean that it all goes right all of the time. It doesn't. But yeah, if people want to raise issues and raise problems, which they do actually, we are here to listen and to try our best to deal with those.
Thank you. Jill.
Yes, thank you. It will be something that I will be discussing in detail at the working group. Thank you.
Thank you, that's useful. Phil Hewitt, good morning, Chair.
Oh, good morning. My apologies, Chair, for being a few minutes late. You was aware that I was at another meeting, not just...
I think I held you up.
Making a leisurely journey here. I don't know. I'm trying to frame a question around my thoughts. And one of the things that's in the report is about promoting independence and how important that is. And it feels at times that there's no silver bullet to solve these problems. But my evidence is only anecdotal. So I can think of 2 people that I've worked with as being a councillor, and one where there's been a real effort to promote their independence, and you see their lifestyle is better and they're in a better place, and I hate to use the less burden, but less burdensome on the government or the council's purse, and that's the case. And then there's another one who I never see any examples of promoting independence whatsoever. And firstly, I don't think their lifestyle's as good because of that. And secondly, from the outside, it looks very expensive. And I wonder whether we're doing enough on that, or whether that there can be more done, and whether, you know, for me, it's twofold. Firstly, the people where we promote independence become substantially less expensive, and secondly, their life is better for it. So my question is very general, Mr. Chairman, but I hope we can pluck something from that. Thank you.
Mrs. Jessel.
I note the last comment, which it's a general comment. I think if members have specific evidence of where they don't believe the quality is there, as Councillor Hewitt well knows, on the odd occasion he has contacted me, there has been a very rapid solution. And I would say that to all members, to Councillor Hood as well. You know, we cater for thousands of people with a whole range of different providers with the best will in the world. Not everything works 100% perfect all the time, but if councillors are aware, you know, issues can either be raised with myself or with the officers, and they are dealt with quickly. I would just wondering, Chairman, if it would help if Amanda carried on doing the other slides, because I'm conscious of this is about the CQC Enhanced Assurance Framework, and we're getting into some of the, what I'll call operational issues.
I've got Phil who wants to come back, and I've got two other speakers just on these areas, but I'm sure they will bear in mind that there is a second half to the presentation. Phil.
Oh, thank you. And thank you to the Cabinet member. And I agree. I've come to on numerous occasions and been helped quickly and efficiently and brilliantly. This wasn't a particular complaint about this. The person I'm talking about is looked after very well. It would be difficult for me to complain, and I wouldn't. The point I'm making, what I see no evidence is, and it's only as I give it some thought, I see no evidence of promoting that independence, of saying, could we go that extra mile? Could we do something a little bit more that would enhance their life? So it would be very difficult for me to come and say, I'm not happy with this because the people are being cared for more. But I look at it and I think, well, could we do more, or could we do more to promote that independence? So I wasn't making a particular, I was trying to use an example, an anecdotal example of whether we could do more. So it's certainly, let's be clear on this, it was no criticism of any of the department or the Cabinet member. Thank you.
Mrs. Jessel.
Yes, I think one of the things I would say is that the underlying culture now is strengths-based practice, which isn't so much about what more can we do for you, but how can we help you to be more resilient, more dependent, more independent rather than more dependent. So I think in terms of our practice, which is a cultural shift that is being rolled out throughout the whole of adult social care, is actually how can we help people to retain their independence, because that is important to people and actually is far better for them. So there is that cultural shift that's been rolled out, well, I think probably over the last 3 years, and continues to do so. And I think one of the real challenges is to make sure that that is rolled out consistently across all the social work teams, and I know a significant amount of work has been done to do that.
Thank you. Phil.
To quote Councillor Atkins, with that answer, I'm content. Thank you very much.
That's always wants the last word, but that's the voice of a chairman. So thank you, Mr. Chairman. Richard.
I think I'm quite happy to actually see the rest of the presentation. I think my question might unfold within that.
I'll put you on first on the once we finish the next bit of the presentation. Jill.
I just wanted to reassure Jill Hood. As an ex-care manager, and I worked with in care, with domiciliary care, visiting people in the community for years and years. And the care workers that went in to these residents were all very well trained, and they did have a backup system that went in to check that things were working well. And we used to have senior care workers who visited at least once a month to make sure that there wasn't any breakdown in the care. Sometimes you find that a resident will want something doing a certain way or a certain time of the day, and they will complain and complain and complain because they can't have a call at 7 in the morning. And sometimes it isn't physically possible for the care agency to deliver that time because they've got other residents that they've had before who've got that time slot. And it's very difficult to keep everybody happy. And sometimes I think that families can also cause a lot of problems and complaints because they think that you should be doing everything for their relative, and that's not always the best thing. It's for the care worker to encourage them to do as much as they can for themselves. And I know it's time limited now, which makes it very difficult, but we can also keep a lot easier track on the care workers now because they have to log in and log out everywhere they go. Whereas before, I've known carers who've gone into someone for a half-an-hour call, they've been there 5 minutes and gone. That doesn't happen anymore, so it's all improvements, and I just wanted to let you know that. Okay.
And I think that's a nice segue into Amanda's piece, albeit it sounded like someone was putting their hand up to join the Health and Care Working Group. And we'll have to think about how those constituents of committees work, but maybe we need a conversation with the chair of safeguarding, but as to whether that's appropriate or applicable. Amanda, we're back with you, if that's okay.
Thank you, Chair. So the next part of the presentation, I will now go through each of the 9 quality statements and pause after each one if there's any questions. So just a reminder that CQC...
Can we just take them all together? Otherwise...
Okay, yeah, I can do that.
Yeah, thank you.
Okay, thank you, Chair. That's easier. So the quality... how CQC are going to assess us is with the we and I statements that are on the screen now. And so this particular one is assessing needs. So our exam question for CQC is that we can demonstrate that we maximise the effectiveness of people's care and treatment by assessing and reviewing the health, care, well-being and communication. And then there's also I statements. So as we talked about, the voice of the person is integral to how CQC are going to be doing their assessments. So there's I statements that they're going to assess against for each one as well. So for each one, we've got our strengths and areas to work upon. So for this one, we are particularly proud of the assessment's timeliness. So we complete assessments within 28 days and also ensure that people receive reviews within 12 months. And also we are not only just in terms of timeliness, but in terms of quality, we put quality audits in place to ensure that we are taking that strength-based approach and very much ensuring that the person is at the centre of their assessments. In terms of areas we want to work on, we're aware that we've currently got waiting times for financial assessments, and we've reviewed our pathways and processes for financial assessments, including in the future offering an online assessment and also telephone assessments to enable people to get that information in terms of how much they may need to contribute towards their care as soon as possible. And as Councillor Jess also talked about, we're keen to continue to embed our strength-based practice and personalisation for people. The second one is around supporting people to live healthier lives. And fundamentally, this is about preventing, delaying and reducing the needs for care and support. Within Staffordshire, we very much focus on information, advice and guidance, particularly through our website, Staffordshire Cares, and also the Supportive Communities programme that's being rolled out and using our community hubs across the county to provide that information to people, whether that be on information on local services, again, tailoring services and working with voluntary sector in terms of the offer. Also included in this section is access to assistive technology, and again we put that on our areas to work upon as well, because we still want to do more as technology develops in terms of ensuring that people have access to equipment to remain independent and healthy. And finally, in the strengths, I'll emphasise how proud we are in terms of our re-enrollment offer, particularly in supporting people when they are discharged from hospital and ensuring that people have access to become independent again after that stay in hospital. In terms of areas to improve on, we do currently have a waiting list with an occupational therapy that support people to remain independent, but we've got plans in place to address that, including investing in additional temporary resource to reduce that waiting list. Moving on to equity, which I think we've discussed slightly, particularly for CQC, this is not just about the protected characteristics, but understanding and addressing barriers to care and support, particularly those people who are more likely to experience inequality in experience and outcomes. So for the Staffordshire County Council, our strength-based approach, very much focusing on the person and that person's strengths, their life and what they want to achieve, their goals, enables us to recognise what's important to that person, whether that be cultural or rural locality or their family. But we want to do more, so we want to engage with community groups to understand that experience and ensure ourselves that people don't have barriers to access that groups. So working with particular community groups to provide that assurance. And there's also some things about recording protective characteristics. We've got good recording, but we can do more as well to provide the evidence and assurance that we understand our communities and therefore can tailor our strategies and plans for that. Next one is care provision, integration and continuity. And this is all about ensuring that we've got a good variety of care providers and there's sufficient capacity to meet demand and now in the future. in terms of the county's responsibility in terms of managing the market within the Care Act. We're very proud of the good quality of care in Staffordshire, as you can see on the screen, and how this compares favourably within of our region and England. Also, in terms of timeliness of sourcing care, we've invested in our brokerage team to support the sourcing of care and have good source of timescales, particularly for those people requiring urgent care in terms of family breakdown or requiring care to be put in place quickly. Similar in terms of areas to work on, we are very similar to many other councils in that our use of direct payments is decreasing over time. However, we are still within comparable to the England average, but we want to do more to understand that, and we're working with people and our practitioners to understand what those barriers might be to adopting direct payments to see if that is something that we can improve upon. Also included in there is some areas that we're continuing to manage the market, such as additional capacity for extra care, care homes with nursing, and our block bud offers. And also continuing to prove how we meet outcomes for adults learning with disabilities. And that paper was agreed by Cabinet in the 19th of July, particularly with an emphasis of supporting people to live their best lives. So that becomes our driver to focus on that particular area. Next one is partnership and communities, and fundamentally how we work with partners to improve outcomes for people. Not just that we have partnership arrangements, but actually that is adding value to people. And within Staffordshire, we have the example of integration, particularly with our agreement with the Midlands Partnership Foundation Trust. And that agreement has enabled us to work in a very integrated way with our health colleagues, and particularly supporting our discharge to assess pathway. So when people discharge from hospital via Home First, that we work closely with our community and acute hospitals to ensure that we coordinate care across the hospitals and social care. And we're very proud that we typically have few discharges that are delayed due to social care. And also that's supported by our reablement service, which is jointly commissioned with the NHS, ensuring that people have access to reablement following a stay in hospital. And we're also expanding that within our communities as well, so people can receive that at home. We are continuing to work with the ICB as a key system partner, particularly in recognition that the integrated care system will also be regulated by the CQC in the future. So we need to work as a partner within the ICS as well as our own local authority assurance. So we will work together and to understand what that looks like. And we're also working with our district borough councils regarding housing, recognising that's such an independency with enabling people to remain independent. Safe systems, pathways and transitions. This is particularly focused on when people move between services. CQC are seeking assurance that when, for example, children move to adult services, people are discharged from hospitals, people move from different settings, that is coordinated and people are kept at the safe centre of that. We have a very effective referral process for safeguardings, and we monitor that incredibly closely, with safety being our key priority. And in the event that we have demand pressures or resource pressures, we move resource quickly to ensure that we address that. We're also very proud of our provider failure processes. So when providers do have challenges, our team working with the NHS support providers and support people in the event that that provider needs to close. And also our provider improvement response team who support the quality of care, working closely with our care providers to ensure quality. We've took the opportunity of the CQC assessment to review our safeguarding quality assurance framework. And we already have plans to look at our preparing for adulthood, working with our partners to ensure that children are identified and engaged with at an early stage when they're transitioning to adulthood, so that we have those plans well in advance of them turning 18. Similar to many authorities, we have a waiting list for deprivation of liberty standards and have invested in external resource to support that and reduce the waiting list. And finally, the last one on that spreadsheet is something that part of our Telford and Wrekin Council came in to do a readiness review, challenged us in terms of, do we have assurance when people discharge from hospital and then contact the council? So based on that learning, we put feedback in place, and we can now understand that when people discharge from hospital, is there any learning from that? And positively, that is already starting to show that people, when they're discharged from hospital, contact Staffordshire Cares, actually that loop is closed. So that's already starting to move into the green space. Safeguarding this one's all about Section 42 safeguarding inquiries, that they are completed sensitively and without delay, and keeping the person at that centre of that, and that people are involved as much as they want to in that process, and that people are supported to manage risks. Again, on this particular example, we've got timely safeguarding, triaging of safeguarding contacts, and also our multi-agency safeguarding hub demonstrates how we share information with our partners to ensure that we are working together. And also, we've got our established Safeguarding Adults Board, which is one of the Care Act requirements. We want to do more in terms of evidencing that we're learning lessons. So as part of our self-assessment, we recognise that we learn lessons, but with CQC, being able to evidence and demonstrate that robustly and ensure that that message reaches all teams across Staffordshire. And also learning from feedback from safeguarding, recognising when people address us with safeguarding, that's clearly a challenging time, but ensuring that we do take that opportunity to get that feedback from people to inform our future processes. Last two are around leadership. So this one is governance management and sustainability, ensuring that we've got robust performance management, we use information to make decisions, and that we manage risk. Again, we've got very robust governance and performance management arrangements, and we regularly report on a quarterly basis to Cabinet and Corporate Review on our key performance indicators across adult social care, and can demonstrate that with evidence. The area we want to work on here is co-production. We've got good examples of co-production in Staffordshire, such as our carer strategy was co-produced, and indeed it's now going through that cycle of co-producing again to review that. But we recognised as part of our self-assessment that there's probably more in providing that consistent approach, so we're using that similar learning in other areas as well. And the last one is learning, improvement and innovation, ensuring we're continuously learning. As Councillor Jessel pointed out, that I'm sure CQC don't expect any organisation to be perfect. What they do expect is that we learn from when things go wrong, and that we learn from incidents and complaints. So, as I alluded to earlier, we've got a quality group that is using this opportunity to collate that learning from the different sources and make sure that we are identifying any themes and sharing that learning. And we have PSW forums and staff quality and question and answer sessions where we can provide that feedback. However, what we do want to do is ensure that we're closing that loop. So we do those sessions, but is that being embedded in practice? So continuing that circle in terms of ensuring that learning is embedding. And also, I think we've already alluded to the collection of people's feedback as well, ensuring that's consistent. Staffordshire is a very large organisation, so we need to ensure that we consistently collect that and identify those themes and share that best practice. And staff feedback is also a key area of our learning. So we already have our Director of Health and Care and the Chief Exec of Midlands Partnership Foundation Trust, for example, You Said We Did session earlier last month to feedback to staff in terms of their learning and what we've done with it. Thank you very much, Chair.
Thank you, and I think it picks up a number of strands of activity that we've been talking about through the first part of the meeting. I did like, just in terms of the format of the slides, that the green areas were bigger text and the red areas to work on were much smaller text. I'm sure that was just sort of a formatting element rather than anything that we should read into that. I'm not seeing anyone indicate, so I'm just going to ask, we'll obviously circulate the slides as well, but there are a lot of areas within the to work on, which if you took on face value, you'd say, you know, they're just part of a long list rather than a prioritised list. And I'm sure there is a prioritised list based on the impact and based on the risk. Have you got those mapped in that way, in some sort of matrix, for example, which would allow committee just a sort of a better understanding of, you know, how that translates into activity on the ground and what you're focusing in on?
We do have a strong assurance improvement plan behind this, which lists all of those actions and more. As you might imagine from the staff feedback, we want to ensure that we collect all that. In terms of prioritising it, we did include the high strengths and weaknesses, but happy to return with further information for the working group. I think that'll be quite powerful.
Great, and obviously one of the actions will be to go through that, no doubt, and just see how that triangulates back up into what we've been talking about. I promised to bring in Richard Cox, so let's do that.
Thank you. As I hoped, I think my question over our staff did actually unfold in that second part of the presentation, because what it was in the paragraph 16E, we've got committed staff, which is absolutely what we want to hear, but we do have those vacancies, and I see that there's obviously a low use of agency workers. So it's a question really around retention of staff and really what methods and practices have we got in place to ensure that our staff are really, because to me, it's our staff that makes the whole thing work. Without them, it's not, is it? So we've got to have full confidence and know that they're going to be there. And we've got the right numbers in the team to deliver it. So I just wanted to have reassurances that we are clear on that, because that to me is where it says our key strengths, but it could also, you could flip it, that if we're not on top of it, it becomes a major weakness, because then you're not delivering. Does that make sense?
I mean, we've obviously got this on the agenda, staff generally, and we saw a presentation, I think, Richard, October time of last year, but maybe you could just provide a brief update on how that then fits in with this plan. I think it's a key deliverable.
Yes, so within adult social care services, both at the council and MPFT, who are our main delivery partner, there are some staff vacancies, and it is a continual challenge to manage what is rising demand within the staff we've got, and it's a challenge that I think staff rise to very well. We have ongoing efforts at recruitment to make sure up to establishment. Recruitment in social work is quite challenging, as it is elsewhere in many health and care services, but nevertheless I think we're reasonably confident that over time we can fill those posts. In terms of retaining people, that's all about making us a good employer to work for, and the same for MPFT. So corporately we have a people strategy which we adopt to try and make ourselves a directorate that's a good place to work for. We get regular feedback from staff, both qualitatively, and we also have this ENPS survey that you might have heard of, that you've seen of corporate scrutiny, which is about staffs are asked a question about whether they would recommend the council as an employer to work for, and we tend to come out fairly well on that. Similarly, in MPFT, they have their own equivalent of the people strategy, which is all the activities they've got ongoing to try and look after their staff and make MPFT a good employer. And again, I think on the whole that staff rate them as a good organisation to work with. So again, we can never afford to be complacent because recruitment is so challenging, but I think on the whole we're relatively comfortable at the moment that staff are engaged and on the whole are enjoying the work that they do.
Julia, I know you want to come in.
Yes, thank you very much, Chairman. Richard has covered staff in terms of Staffordshire County Council staff and MPFT, but actually the services that we provide are provided by a whole range of external providers as well. And I think we did a fairly unique piece of work jointly with NHS partners, jointly with private providers. There's a Staffordshire Association of Care Providers who worked with us as well to develop a social care workforce strategy. Because it is important that, A, we raise the profile and the status of people who work in what I call those caring industries. There is definitely a shift. During COVID, people applauded the NHS, but didn't applaud the care workers who actually kept everything going. And the strategy was approved 4 months ago, about 4 months ago. And it's so important because it helps for people to identify how they can access the services, not only school leavers, but people throughout their career development for those who want it, the training, and we're working with the local further education and higher education establishments to ensure that there is that opportunity for career progression, which is so vital to making it an attractive career for people to join. You know, we don't underestimate the difficulties, but as I say, it has been identified as a fairly unique piece of work that we've done in Staffordshire. So Richard's identified the here and now. I'm a great believer in you have to plan for the future, and I think that strategy will certainly help. Thank you.
Thank you, really useful. In as much as I think you highlight the importance of seeing social care as a career for people and the importance of it, particularly as we all get older. And you're right, I think it was February that we saw this, not October, but I think we're seeing an annual review of those actions. And there was some discussion last week in the ICS, the Integrated Care Systems discussion regarding end-to-end employees as well. And we have the roundtable maybe 2 weeks' time, maybe it's next week, I can't remember, but we've got the roundtable with some of the social care providers. Richard, let me bring you back in.
I'm very in line with my colleagues. I'm quite content with the response. I just felt that it was important for me to ensure that it's focused, and it clearly is.
Thank you. We'll not give ringing endorsements entirely through the whole of the day. There's an open point in having a working group. Janice.
Thank you very much, Chair. I'll start. I've got a couple of questions, if I may, and I'll start on the emphasis being on the process, not necessarily scrutinising the numbers in this session. One of the aims was to say about the financial reviews, and I think the phrase is reduce the amount of time. Is it to catch up? So within 28 days, we've got an element that isn't to do that. Is it likely that it will never be 100% because there are just naturally some very complicated cases when it comes around to financial reviews? And I think it was just a bit of the terminology there with that context. And then my second question, ironically in the news today, I was reading before starting this meeting, it emphasises and highlights the delays for patients who are medically fit for discharge, which of course is one of the aspects in here as well. And again, the phraseology is about reporting reduced and removed, but there appears to be still delays. So whilst there is an element of a question there about how we're phrasing some of those, it also emphasises my previous points in the session earlier about how we can look at checking off data that is being supplied to us. So particularly in the news, it shows that 23% of councils of whom participated, which implies that an awful lot didn't, say that there is an average delay of over 1 month. An average delay. To me, we can draw out from that it shows the size of the task in hand, but also how some of that information is presented. So there's a couple of statements and questions in there, if I may. But yeah, if we could, that would be very helpful. Thank you.
Richard, we're with you.
Yes, so we measure our social care journey in terms of, so we typically give ourselves a timescale to complete a certain task, so be it an assessment or finding care, and we measure the proportion of people that achieve that timescale. It will never be 100% because, just as you say, there are some people who are very complex that just take longer to work with, and actually they wouldn't want it done within a month because for them that conversation needs to take a bit longer. So for adult social care assessments, we have a target of 80% completed within 28 days. I'm just looking at the graph and it's showing 83% at the moment. And that's been pretty consistent, so I think we're reasonably comfortable with that one. And then for finding a service, we have a it's a 28 day as a standard target, but there are some people where it's very urgent, where we have a 24-hour target. Urgent care is a 7-day target. On the whole, we're hitting 95% sourced within timescales at the moment, so that's actually doing really well. For financial assessments, historically we don't quite manage it in the same way, so one of our tasks is to get more formal performance management arrangements in place for financial assessments. And then the challenges are twofold. One is that there is a backlog currently, so we need to catch up with all of those. And the other one is to make sure that all incoming work is being dealt with within a reasonable timescale, just as I've outlined for the assessments and people entering care. In Staffordshire, delayed discharges from hospitals due to adult social care are not currently a big problem. We have integrated discharge arrangements in place, and they do work for us really effectively, so that the number of people who are delayed in an acute hospital because of adult social care on any given day, I can usually count them on the fingers of one hand. And that's across all our acute hospitals, both in and outside county. So that's particular metric is not one that we currently have concerns about, but again, we monitor it pretty carefully. These things are volatile, they can change, and it's important we keep an eye on them.
Thank you. Janice.
Yeah, thank you very much for that. I think that the emphasis as well is also showing how we can use the data to compare with other sources and how we are performing, because predominantly it's Staffordshire that I'm interested in. Are we participating in these things that are being reported nationally? And in some cases, it only takes one, although I appreciate you just said it's not a big problem, that could be waiting for an extended period. And in that particular example, they were showing us 11 months. But as I say, my interest is predominantly Staffordshire. And then just to clarify, so the financial reviews, the intention is that the backlog will be caught up in that year, which is what's in this part. Again, it's the process that I'm just trying to establish, not scrutinising the details. If I can just reiterate that, thank you.
Yes, so for financial assessments, we are very keen to both address the backlog and get in place a new process that can deal with incoming work in a timely way, ideally before the CQC come calling. Your point on benchmarking is interesting. So there is no standard national way of measuring social care flow. So if you contrast it with the NHS, where they measure things like number of people who have elective surgery within 18 weeks, and all hospitals do it the same, so you can compare. Local authorities measure their own performance differently, which makes comparison between local authorities quite complex. You can argue about the virtues or otherwise of having a standardised national system, but what we need to do is to make sure that our own system of measurement is robust, and that we understand what it's telling us, and that we're doing something where there are problems.
Can I bring in Julia? Do you want to add anything?
Richard's covered the point regarding financial assessments. We recently, through the annual complaints report, reported to the safeguarding overview and scrutiny details of the work that's been done to streamline the financial assessment process. So it's not only catching up on some of the backlog, but it's making sure that we streamline the process from now on. So we anticipate some improvements in that area.
Very quickly, if I could just say as well, Chair, that I think the detail in here has been very helpful, and I do appreciate the opportunity to have that dialogue today, just to thank members for that as well. Thank you.
I mean, it's certainly a critical issue in terms of the national press, in terms of delays to discharge. The only point I would probably make in addition, though, is one shouldn't just assume that delays to discharge is down to social care. And actually, sometimes it's down to other issues outside of social care, family members, somewhere appropriate to go, you know, those sorts of things. I think this is Pathway Zero, is it? Is that the one, Richard, which is the one which is related to social care, which is the one we should focus in on? And I do know that the leader of this council had been down to Westminster to argue about funding, not about delays to discharge. So,
quick catch-up on hospital pathways. So the NHS will tend to quote 4 discharge pathways. Pathway 0 is you just go home. Pathway 1 is you go home with some support. Pathway 2 is you go into a rehabilitation bed, often a community hospital. Pathway 3 is you go into a longer-term care bed. The best way to make the biggest difference to timely discharge is to maximise the number of people on Pathway 0, just go home. Because if you get that right, everything else just falls into place. So the question you should be asking of NHS colleagues is what proportion of hospital discharges are on Pathway 0?
And I think we did actually ask that question last Monday, if I remember exactly rightly. I don't remember who asked. Oh, yes, I do. Okay. We mentioned the Safeguarding Committee, so it's time to bring in Bob.
Chairman, thank you. And I thank you again for the report and taking us through it. It's a very comprehensive action plan, and it looks right to me. I suppose you'd expect just a couple of questions on safeguarding. And rightfully, you talk about learning lessons from safeguarding audits. Inevitably, after all this time, with all of the infamous cases that have happened, the problem is around sharing information. And that comes up time and time again. And it may well be difficult for you to make an assessment. Firstly, are we happy that that information sharing is robust enough for us to be able to have some confidence that very vulnerable adults are safeguarded? And secondly, on that point as well, you'd probably be aware there's a national strategy with police forces, including Staffordshire. It's called something like Right People, Right Place, Right Time, I think. I might have the title slightly wrong. But in essence, it's about the police, one of the main partners, in effect retreating from doing things that they don't see in their remit. That normally is responding to some of the most vulnerable adults in our societies. And I just wonder whether this plan takes account of that potential strategy, which I understand Staffordshire will probably implement at the end of this year. Part of which, of course, is about how well vulnerable adults are managed before they get to a state of that sort of chaotic need where the police provide that safety net. So really, have we taken that into account? Thank you.
Thank you, Chair. So on the first point, I've got no concerns at the moment about the way that agencies work together and share information. I think we collaborate pretty well. I think the second point is well made. I think it's called Right Care Right Now, and we do have some concerns about whether it would compromise the police response to situations where an individual who is very disturbed might pose a risk to themselves or others, including our staff, and where historically we've relied on the presence of police to help manage those individuals. And if that police response were withdrawn, again, it might introduce some risks. So I think you're right, we might want to take that into account when we're sort of finalising this self-assessment, depending on how that policy evolves.
Can I bring in Julia before you, Bob?
Yes, thank you very much, Chairman. This is the new police policy on dealing with people who have got these mental health issues. I believe that the chairman of the Health and Wellbeing Board has asked for it to be put on the next agenda, because this has to be dealt with across the system for the police to make a fairly unilateral decision without discussions with NHS and other partners as to how else these people are going to be dealt with. Not least, the ambulance service are not equipped or trained to deal with people who are in an extremely agitated condition. So it does have to be something that is addressed across the whole system. I having worked in custody suites and seen the difficulties that there are, I understand the frustration that the police have, that the time that they are spent accompanying people awaiting mental health assessments. I fully appreciate their frustrations, but the solution is not making a unilateral decision on your own. It's actually working with partners to make sure that these people who are in a very vulnerable state themselves, can be a danger to themselves and members of the public, are dealt with in a proper and timely manner. So I understand Councillor Mark Sutton has agreed for this to be put on the Health and Wellbeing Board agenda, and I think the police have been invited to come and present to that board.
And I'm sure that Bob will be very interested in having a feed into that as well. Bob.
No, thank you for that. I think it's hugely reassuring that we do have confidence that the information sharing processes are robust. And again, it's reassuring to hear that we already have an understanding and a handle on the impact that this strategy might have. So thank you.
And just as an aside, I've just asked for it to go on to the triangulation of scrutiny chairs next meeting, because there's clearly an overlap between safeguarding and health and care. And we've got to make sure that one way or the other it's picked up. So thank you for raising that. Let us move on. David Williams, good morning. Welcome.
Thank you, Chair. And firstly, that's really great that we've had that discussion about right care, right person policy. From my point of view as an armed forces champion, you know, thinking about armed forces, veterans and mental health, I think it's really important that we get that on the agenda, so that's really assured. My question actually goes back to Councillor Hewitt's discussion around independence. And in the action plan, and thanks, that gives some loads of context, you talked about OT's waiting list, but you also talked about re-enablement services at home. And I know in the last meeting, I wasn't there, but you talked about, there was some discussion around deconditioning. And I know in my practice as a healthcare professional, inactivity and reduced activity, especially in the elderly population, has a real impact. And we know up to 2%, they can lose up to 2% of lean body mass just from prolonged immobility. And that can happen as well in a sort of care situation. So really it's around, my question is around, how are you mitigating that OT waiting list? Because obviously if people in their homes aren't getting access to occupational therapy, they might not get the equipment. But also I'd love to know a bit more about that re-enablement service. Because really I think the key part of the discharge to assess pathway is about enabling that rehabilitation and all those other good stuff that I think is really important. That needs to happen in the home, and sometimes it doesn't. So any thoughts on that would be much appreciated. Thank you.
In terms of the OT waiting list, the occupational therapy waiting list, just to give initial reassurance in that obviously everything that comes in is assessed and prioritised. So the people that are waiting on that waiting list are the lowest risk. So that's not acceptable, but that we do ensure that those people at the highest risk do receive that occupational therapy assessment. And also we put in place initial, it might be that part of the occupational therapy assessment has been completed, so there's an initial response, but then we recognise that further work is required. We've invested additional resource and MPFT have recruited additional temporary resource to focus on the backlog to remove that, but then also recognise that we need to look at our pathways and processes to ensure that we're putting that occupational therapy question right at the start, so not preempting what that redesign will look like, but ensuring that where we are putting that expertise as early on as possible, as you recognise, in terms of making sure that we're not creating those delays and creating additional risk to people. In terms of reablement, from our end-of-year figures, 71% of people receiving reablement from a discharge from hospital resulted in no ongoing support. So again, that pathway, pathway one of providing that reablement capacity, enabling people to gain those skills and remain independent. We also have incredibly low waiting lists in terms of people often not waiting longer than over one day in terms of access to reablement service. So we are really fortunate in Staffordshire of our integrated relationships to ensure that reablement is put in as quickly as possible to enable people to go home.
That's really encouraging, thank you.
Brilliant, thank you. And there's been some changes in some of those systems as well, and maybe just worthwhile us at some stage as a separate strand of activity coming back to what you just described and talked about. And Jill.
My question's about the care staff. We say that they're looking after vulnerable adults, but they become vulnerable as well because they're going out and they're getting verbally and physically abused in some cases. And also, they haven't always got the right equipment to deal with moving and handling issues. And I've been in care homes, in particular, when I've worked up with the agency on night shift, where they've had people in ordinary single divan beds that should be in hospital beds. And this is causing the staff to go off sick with bad backs and various issues and that. How can we deal with those issues? And do we look at those on a regular basis?
So I think it's important to put that into context. So we did do a survey as part of the care workforce strategy, and it is true to say that for most care staff, enjoy most of their job most of the time. It is a rewarding career, and I wouldn't want people to be put off going into the sector. That said, there are adverse incidents that happen all the time, whether it's difficult interactions with clients, environmental factors. I think for people working in a care home, if there are issues with equipment, the first point of call is to the management and the ownership of that care home. I think it's that care home that would need to resolve it, because by and large that is what we are paying them to do. We are paying them to provide a service for that individual. Where there are very unusual and unique requirements that an individual has, then we will have those conversations on an individual basis with the provider about particular specialist equipment which is essential to provide care for that person. But on the whole, I would regard that as the responsibility of the provider to be resolving those issues.
A lot of time, though, when these people, you go in as an agency worker into these care homes and you point these things out, they just say, oh, we don't want her again because she's complaining. And the other staff are just putting up with it because they need the job. And it's these little care homes that seem to be able to get away with it. And they sort of say, well, they haven't got long left now, so it's a shame to move them into nursing when they can stay here where they've been a resident for X amount of years. So it is difficult.
Again, care providers are independent companies. We can't control what they do. Where there are serious or recurrent concerns about the quality of care being provided, then we do ask that people let us know, and we do follow those up. We do investigate, and we do take remedial action where necessary.
Brilliant, thank you. I think that brings to a natural conclusion the questions from around the chamber. Notwithstanding that I'm sure there's lots of detailed questions within the strands of activity that Amanda presented, which should rightly get picked up by the working group. So Julia, Amanda, Richard, thank you for the presentation. Thank you for answering our questions across a whole diverse, many of them actually, it shows the diversity of the people in this room, which is helpful. So the committee is asked, first of all, and I think this is quite easy to do, the committee is asked to note the introduction of the Adult Social Care Enhanced Assurance Framework from October. I think we can do that quite easily without too much difficulty. And then the second point, which is, so how do we provide that assurance to both ourselves, our residents, and to the CQC about the robustness of the work that's done within the County Council across the whole of social care. And obviously this is a series of conversations we've had. We've had social care come up a number of times. Julia, Richard and colleagues have brought that to us a couple of times, 3 or 4 times in the last 12 months. But how do we dive into the next level of detail? So the proposal is to establish a working group. Are we in favour of doing that for committee members? Yep, that's fine. Okay, so if we're in favour of doing that, can I make a couple of suggestions? First of all, we need some members who are prepared to do some work. That's the nature of the title, on the working group. Given the timescales that we've talked about in terms of the critical pieces in terms of October, I can see this will be a bit of an ongoing strand of activity in that there'll be less time critical stuff that we want to come to afterwards as a working group, but to really get into the details. So first of all, do we have any volunteers at this moment in time to join the working group? I've got Phil Hewitt. Thank you, Phil. They're always early. Jill, thank you. Bernard? Anyone else, Jill? Okay. No, I didn't take that as a positive. Okay. So we've noted those down. I will ask Zach just to write to the committee who aren't here today, just to express if they want to join that working group. And obviously, if anyone sort of gets home this evening and thinks, well, I really should be joining that working group, please do contact Zach. We'll look for maybe 4 to 6 people maximum just to do the detail work on that. I think we've got some strands of activity that we've started talking about today. We talked about ensuring that we look at the voice of residents, contracts, and that they're fit for purpose, culture within the organisation across whole of social care. I think we talked about staff, but not just staff in terms of recruitment, but also in terms of, that environment that they work in that Jill referenced. The resident and patient journey, finances, because in the end you can have the best system in the world, but if it isn't financially viable, then that's problematic, but also financial assessment. So I think we're beginning to sort of create some bits that we can create themes around. What I'm going to suggest is that working group comes back to committee with a set of terms of reference that they sign off with committee and then just get on and do the work. Are we happy with that as a process? Are we happy that we haven't missed anything from that? No? Okay, good. So I think that is a very clear set of actions, and I would thank Julia, Amanda and Richard for your involvement this morning. Let me move on to the next item on the agenda, which is number 4. I've woken up now. I understand where we are. And we're on page 13. So just very briefly, understand there are multiple new committees across districts and boroughs. So first of all, for those who have approved the revised terms of reference for this committee and the interface between districts and boroughs, thank you for doing so. And for those who haven't yet, I would encourage you to try and get those ratified so that we're all in the same place. If you don't know what I'm talking about, then please do approach Zach or myself, and we will try and guide you through where that is, because I would guess it probably just needs some amendments to your own constitutions, much like it has within the County Council. It's not a sea change, it's just really an update. So that's the first thing. Second thing is that we often talk about the preventative agenda, and particularly the impact of housing on health. And I know there was particularly some good work that was going on in districts and boroughs last year and in previous years, just to pick up some of those strands, and that Public Health, Richard, through Claire McIver and colleagues would be more than happy to come and talk to and present down at district and borough level on some of those levers that are within district and boroughs' controls. Given that these committees are member-led, I would encourage you to take that interface and see whether there is anything within that interface that may be beneficial to you and your residents in terms of increasing healthy life expectancy, not just life expectancy. So that moves me on to just the individual updates that aren't noted on the report. So are there any districts and boroughs who have met recently who would like to provide an update on activities or their forward agendas? Keith.
Just wanted it to be noted that unfortunately I didn't make the last meeting for the district one because I wasn't realising I was the link between the two committees until after I was informed of that after the meeting itself. So I was a bit surprised. But anyway, I'm quite happy to fulfil that role. But they did come out, and it was suggested at last week's meeting as well, that they do want to try and approach the West Midlands Fire Ambulance Service on an urgent issue around responses around defibrillators, which I think we did mention last week. So I don't know whether we can agree that we can have a look at that at district level or whether that's needed at all. I'll just take some advice from yourself, Chair.
Yeah, I think given the discussion last week, I think the outcome from last week's discussion, I'm just going to look at Zach and hopefully he'll nod, was that we were going to get a written response on two issues. One was about ambulance times across the whole of the districts and boroughs, just to see if rurality is a key issue. And we often discuss that, and I think that we need to see the data, and then maybe it is a individual district issue, maybe it's a wider issue without seeing the data. Really difficult to say. And in terms of your very specific point about access to defibrillators, again, we wanted to have an assurance in writing from West Midlands Ambulance Service. If there is a different process in Staffordshire Moorlands to the rest of Staffordshire, then we need to understand that and why, because I will be surprised at that, but one should never rule anything out. So we have asked for a written response on both those issues. And then I think once we have that information, we'll be able to determine whether it is a local or it needs to come here or we need a wider response, if that's okay.
Yeah, that's fine. I just wondered what timescale is going to be put onto that, because I think they were very concerned at both the full council meeting and at the health subcommittee meeting. So.
Yeah, and the reference was there were some people a couple of people badly affected by the lack of access to a defibrillator. And clearly one of the things we wouldn't want to be doing is waiting excessively. I would hope that certainly by the end of the week that we had a response, because I think a 2-week response rate would be perfectly acceptable. And if it hasn't come through by then, we will escalate within the ambulance service.
Can you keep me informed on that as the link between the two committees?
I will. We will keep all members informed, but absolutely, and by all means, put a call into either Zach or myself if you've not seen anything by Friday. Rest assured, we won't be sitting on that any length of time. Do we have a Canuck, David?
Yeah, so I can just add, thank you, Chair. I can just add some more updates to the details on the paper. So Cannock Chase District Council. So we met on the 17th of July. We're forming some working groups at the minute, and we're going to look at the letting standards of social housing with a bit of a health inequalities lens. There was also some discussion in the room around sustainability, and so we're possibly looking at some work around that, although that's a massive topic. So yeah, just to let you know that we're looking at housing again this year, and the next meeting will be on the 18th of September. Thank you.
Thank you, and I would encourage you just to avail yourself of any of the public health officers in terms of housing within the county who can support you on that journey, because obviously anything that we can do to help and share best practice across districts and boroughs, then happy to do so. I'm not getting any further indications, so on that basis, sorry, I have got a further indication. Sorry, Bob.
Thank you, Chair. Just very quickly, the bottom of page 15, where it talks about community safety partnership action plans, and it talks there about the county council's outcomes for the year 23 to 26. I think that the issue around crime here is because obviously it affects reassurance and well-being, and I very much welcome the reductions or the commitment to reducing crime. And I'm sure a lot of people might think, well, that's what the police do. But to be fair, the police haven't done that in any significant way for probably the last 10 years. And during some of that time, of course, we've seen double-digit percentage increases across the board in various crimes. The previous strategy was one of reassurance and talking about victim support that we would all be familiar with. And forgive me, but I also sometimes think, you know what, I welcome the reduction targets. There's nothing more reassuring than not being a victim in the first place, of course. What I am just a little disappointed with, I suppose would be best described as a bit of a lack of ambition, where we see recorded crime and the target's 2% across the board. In particular, violence against women, which is something that is or has been topical for some time, and we've set ourselves a target again of just 2%. I just wonder is that really the best that we can hope for and the best that we can do? And also just a slight, whenever statistics are involved in policing, it does create some perverse incentives and by that some perverse outcomes. And if I draw your attention to page 16 and the last bullet point at the top, about feeling safe during the day and at night, and I know that these are national measures, but for example, feeling safe after dark, there's quite a lot of evidence-based practice to suggest that the majority of people who feel unsafe are the elderly and the otherwise vulnerable, and particularly those that are isolated and in rural settings, which clearly makes it more relevant here in Staffordshire. Therefore, because they are represented in the overall stats, you could easily have up to half of the vulnerable or elderly people living in an area feeling unsafe, and we would still meet that target. And I do wonder whether, you know, we then end up with half of our vulnerable people feeling unsafe, and we consider that a success. I do think that there needs to be a little bit more around perhaps some better ambition than we've currently got, and also be aware of the perverse outcomes that when we set percentage targets. Thank you.
Thank you. Really useful discussion and contribution. Again, I think this is probably a discussion for triangulation, because I wouldn't have naturally seen this within our remit in terms of health and care. But I think that word that came up earlier, co-production, you know, there are a whole variety of people who've got a stake in much of this. You know, the voluntary sector, our districts and boroughs, clearly the police and the county council as well. And, you know, and that goes across antisocial behaviour, domestic violence, and this whole importance of recognising the fear that many women have in our communities. I read a report last week that suggested that 25% of women using parks didn't feel safe. You know, that's a significant number when, you know, women represent 50% of our community, and we wouldn't put up with that in our communities. And I do think that's an important recognition. So I'm going to suggest that we take that back as a discussion for triangulation. Bernard.
Chair, if I may just go back to the report from East Staffordshire Borough Council. Activity provision and how those are targeted towards diabetes. I raised that point and said that it should be more reference to type 2 diabetes and obesity. So those words look to have been omitted. But I thought that should be the emphasis, really, in the light of the significant rise in those cases.
Very useful contribution. I think you made exactly the same point last Monday, and which I welcome. Maybe we can go just back to the relevant officers within East Staff's just to make that clarification, because I think it's an important one, because we all need to see the difference between type 1 and type 2, and thank you for making that. Are we in agreement that we do that on? Yep, that's fine. Okay, any other further contributions in terms of this agenda item 4? I think that was a good debate, and that I've got nothing to exclude the general public to discuss. So that takes us through to the next meeting is on Monday, the 11th of September. Thank you for your contributions again today, particularly after last week's exerting marathon. We're back on the 11th of September, but don't get me wrong, there are 2 working groups, if not 3, because there's the social care working group, there's the women's health working group, and the integrated care hubs working group. So don't think for a minute that there is no one doing any work for the next 6 weeks, because you guys will be. Thank you. If you're away on holiday, have a good holiday, and thank you for attendance. Thank you. Bye-bye.